So we're going to have Dr. Kit Wong, who is going to speak a little bit about GI and pancreatic tumors and go from the GI perspective. So please welcome Dr. Wong.
So thanks very much for having me here. I'm a GI oncologist at Seattle Cancer Care Alliance, and today I have the pleasure of talking to you about GP-NETs, or gastroenteropancreatic neuroendocrine tumors, from a medical oncologist perspective. Let's see if I can turn it. Is that better? How about that? Okay, that's better. Okay. No disclosures. So just to clarify some abbreviations that I will be using, so NET stands for neuroendocrine tumor, PNET, pancreatic neuroendocrine tumor, and GPNET stands for gastroenteropancreatic neuroendocrine tumor. So neuroendocrine tumors were first described in 1907 by the German pathologist shown here, Dr. Oberndorfer, and since then a lot has, in terms of advances, a lot has been done since then. So neuroendocrine cells are found in many different sites of the body, and they're cells that can produce a variety of bioactive amines and peptides, and these can sometimes cause clinical symptoms. And neuroendocrine tumors are defined as neoplasms, epithelial neoplasms with neuroendocrine differentiation. As you can see in this diagram, NETs can arise in many different parts of the body. So we have neuroendocrine tumors of the foregut, midgut, and hindgut, as well as pancreas. Those of the foregut, midgut, hindgut are called carcinoids. And the midgut NETs are the most common among carcinoid tumors, about 70% of cases. And there are also some cases of neuroendocrine tumors with unknown primary. It's where the primary site cannot be found. But a lot of times when you have liver metastases associated with a well-differentiated neuroendocrine tumor histology, they most likely arose from one of these sites. So this is the distribution of the various types of NETs. As you can see, carcinoids are the most common, followed by unknown primary and a couple of others, PNET subtypes. So this is a recently published analysis of SEER database, including over 64,000 NETs patients, any NET, from 1973 to 2012. As you can see, there has been an increase in incidence of NETs over time. The blue line illustrates the incidence of all other tumors, and this illustrates the incidence of all NETs in the US. And there has been a 6.4-fold increase in incidence. Moreover, the increased incidence was observed across most sites of tumors, so lung, stomach, all of them are listed here. And there's also been an increase across stage and grade. The most significant increase in incidence occurred in localized disease and also grade 1. And we think that the trends for the increased incidence and also earlier stage migration probably relate to the fact that there's better diagnosis, more awareness of the disease. So I'm going to focus the talk on GP-NETs, and they're a rare group of tumors, about 1% of all malignancies. And as a group, they're very heterogeneous with respect to biology and behavior. So currently, these GP-NETs are classified based on their inherent proliferative potential. The currently used classification system is the 2010 WHO classification, which is based on two markers, Ki67 and mitotic count. So this is just some pictures showing how these parameters are determined. So the pathologist will take a look at the slides under the microscope and count these mitotic figures. The dark spots there, they're chromosomes. And then also the Ki67 is where they stain the tumor with this proliferative marker, Ki67, which is a nuclear protein, and they quantitate the percentage expression. So going back to this classification system, you can see that tumors that have less than 2 mitoses per 10 high power field and Ki67 less than 3% are called grade 1. Those that have 2 to 20 mitoses and Ki67, 3 to 20% are called grade 2. Yes? Oh, it's gastroenteropancreatic. It's just too long to say. So it's GP nuts. So yeah, so those are grade 2. And grade 1 and grade 2 tumors are considered well differentiated according to this classification. Any other tumor with markers greater, like beyond those here, so more than 20 mitoses and more than 20% Ki67 are called poorly differentiated or grade 3 tumors. Those are quite separate in terms of behavior. They're more aggressive. So they're actually called neuroendocrine carcinoma rather than neuroendocrine tumor. So my talk will focus on well-differentiated subgroup, and this includes the carcinoma tumors of the GI tract as well as pancreatic net. The other term for it is islet cell tumor. So there's some controversy in terms of this classification, and the classification is constantly evolving about how to handle tumors that are intermediate between the poorly differentiated and the grade 2. So tumors that have high Ki67 but low mitoses, currently they're still considered in the poorly differentiated group, but their prognosis is probably different from that of a truly poorly differentiated carcinoma. So in terms of prognosis, we generally think that well-differentiated GP nets are indolent tumors. But again, as I said, it encompasses a wide range of tumors with different biology and behaviors. And the recent data that I show from the SEER database indicated that there are a couple of prognostic factors. So these include stage of diagnosis. As expected, localized disease is better than distant or regional spread. Well-differentiated tumors tend to do better. Also, age of diagnosis, younger patients tend to have better prognosis. The primary site seems to make a difference, especially with appendiceal tumors. They tend to have better prognosis. And patients who are diagnosed more recently, from 2008 to 2012, tend to do better as well. And this is likely because there are better treatment options now. So this is breaking down survival by the site, stage, and grade. As you can see, appendiceal tumors have the best prognosis in terms of median overall survival. And patients that have localized disease in grade 1 also tend to do best. So each type of GP net, as you know, can produce a variety of different bioactive substances that can cause symptoms. And the morbidity of this disease really relates as much to the clinical symptoms as much to the spread and the metastases. So each tumor can be described as functional versus non-functional. And this is a table showing the different syndromes that can happen. So in carcinoids, due to serotonin release, you can get flushing, diarrhea, right-sided heart valve problems, as well as wheezing from bronchoconstriction. And typically, it's more common in the mid-gut nets and less common with the hindgut and foregut. And typically, it happens when patients have extensive metastases in the liver. With PNETs, there are many different types of syndromes depending on the hormones that are released. And so these are listed here. I'm not going to go through all of them, but if the tumor excretes insulin, then you get hypoglycemia, gastrin, you get ulcers, etc. In general, we think that whether a tumor is functional or not really does not determine the prognosis. The prognosis is still primarily driven by the grade and the stage. Tumors that are functional clearly need treatment to treat the symptoms as much as treating the tumor to control tumor growth. So this is just a table showing the characteristics of the various carcinoids. As you can see, the carcinoid syndrome tends to be more common with the midgut. And these show, the table shows some of the peptides are released, and serotonin tends to be more common in the midgut nets. So just a slide about the carcinoid syndrome. It occurs in 8 to 30% of patients with NETs, again, mostly in patients with liver metastases. It's a consequence of serotonin and other vasoactive peptides. And this histogram shows all the different symptoms of carcinoid syndrome. Flushing is the most common, 94%, followed by diarrhea and also heart issues, at 50%. So one slide on carcinoma heart disease. It's thought to occur in about 50% of patients, eventually in those with the carcinoma syndrome. And the pathogenesis relates to the serotonin in the blood. And this causes plaque-like fibrous material on the heart valves, well, also other parts of the heart, but classically involves the right heart valves. So symptoms early on may include fatigue, but later on, as it progresses, you can get symptoms of right heart failure. So leg swelling, ascites, shortness of breath. And treatment for it is really treating this carcinoma syndrome. But if it gets severe, then valve surgery could be considered. So most GEP nets are sporadic, more than 95%, but a small percentage of cases are thought to be related to hereditary syndromes. So about 5% of PNETs have inherited gene mutations in a couple of genes. There are occasional cases of small intestinal nets that are also thought to be hereditary. But most cases are sporadic, and genomic studies have been done on these tumors. Generally, unlike other cancers, there are less activating oncogenic mutations found in these tumors. Most mutations are found in tumor suppressor genes. But some studies have found recurrent mutations in this pathway called PI3K AKT-mTOR pathway, illustrated here. It's a critical pathway for cell survival and proliferation. And this also relates to the therapy that we'll touch on upon later with everolimus. And moreover, studies have shown that cell cycle dysregulation might be important in this disease. So a bit about somatostatin receptor biology. So normally somatostatin binds to receptors on cell surface to mediate a whole bunch of different functions. There are 5 different types of somatostatin receptors in the body, and they're found in different types of tissues, CNS, GI tract, endocrine and exocrine glands. And in terms of functions, normally in the body, it serves to, it usually has an inhibitory function. It inhibits GI motility, secretion of hormones. The significant thing is that GEP nets, over 90% of them express somatostatin receptors. And this has implication for diagnosis and staging in terms of functional imaging, but also for treatment, because we know that the lack of somatostatin receptor predicts for a lack of response to the analog. And also some studies have found that the somatostatin receptor expression is prognostic. Those tumors that express the receptor tends to have better prognosis. So in terms of diagnosis, as was previously mentioned, it can be challenging because the symptoms are very subtle, non-specific. Patients are often misdiagnosed, or symptoms are mistaken for other conditions. And as a result, patients are often diagnosed at advanced stage. So about 40% or more of GEP nets are diagnosed with metastatic stage, even higher in small intestinal nets. So the goals of workup are to identify the primary site, assess the stage or extent of disease, characterize the aggressiveness by looking at the tissue, the Ki-67 and mitotic count, and also establish functionality. So NCCN guidelines recommend getting multiphasic CT MRI plus or minus CT chest as indicated. But importantly, all patients should get somatostatin receptor-based imaging. So previously, we used to use OcuScan, and as Dr. Liu talked about, the gallium scan is now becoming the standard, which is a lot more sensitive. Endoscopy, as indicated, to identify the primary labs, tumor markers. Here, if suspected carcinoid syndrome, pathologic assessment, and finally echocardiogram if somebody has a carcinoid syndrome in order to assess for carcinoid heart disease. And somebody with the carcinoid syndrome should really get echocardiogram every few years to assess for valvular problems. So this is the gallium 68 dotatate, the PET tracer that's used in the gallium scan. Just generally, in general, so PET tracers the structure is illustrated here. There's a vector that helps the tracer bind to the target cell. There's a linker, and then there's a radiolabel complex with a chelator that's bound at the end, so that helps to detect the tumor. So the tracer that's used in the currently used PET gallium dotatate scan is this one here. So this is the gallium 68 radial tracer bound to octreotate which is basically octreotide, somatostatin analog. So I think Dr. Lewis also already went through this in detail, but you can see how much more sensitive it is in terms of detecting small volume disease. And in a prospective study that was done, it showed a much higher rate of detection of lesions compared to octreoscanned and regular imaging. And just in terms of practical logistics, if you're on octreotide, it should be stopped. If you're on long-term octreotide, it should be stopped 5 to 6 weeks before getting the imaging for accurate analysis. And also, these scans are not recommended for routine surveillance because they detect the density of receptors, not really actually the tumor volume. So these are just more images showing regular CT octreoscan not performing as well as the bottom panel, which shows the dotatate scan. So you can see the smaller lesions are better detected here. Just more of the same. So in terms of endoscopy, again, it's to identify the primary site and obtain tissue if possible. So there are different types of endoscopic techniques, but for gastric, duodenal, and pancreas, typically EUS, EGD are used. For small bowel, there's some modalities for small bowel imaging, such as capsule endoscopy. Colonoscopy is probably done in most patients to look for colonic and colonic lesions. So in terms of biochemical measurements, NCCN guidelines recommend, NCCN guidelines recommend measuring these secretory substances in patients with suspected symptoms. So chromogranin A is actually ubiquitously expressed in neuroendocrine tissues. They're stored in secretory granules and they get released by the neuroendocrine cells. And so it's a useful marker to detect neuroendocrine neoplasms. It's elevated in over 90% of patients with known carcinoid syndrome, so it's pretty sensitive. So most midgut and hindgut nets release chromogranin A, but not foregut. Well, it can be released by foregut nets, but more likely with midgut and hindgut. And the thing with this is that it can be falsely elevated for different reasons. So observing the trend is more important than looking at a single value. Okay. And chromogranin is a sensitive marker that can be used to follow patients on treatment and also for surveillance after they get the resection. Serotonin is a bioactive amine that's secreted mostly by midgut nets, so that is typically measured as well in somebody with suspected carcinoid syndrome arising from midgut net. And 24-hour urinary 5-HIA is a metabolite of serotonin, and that is highly specific for carcinoid in somebody with symptoms. So false elevations of these markers can occur, and these are some of the things that can lead to false positive results. So for chromogranin A, any drug that stimulates secretion of the neuroendocrine cells can lead to a falsely high result. So proton pump inhibitors are notorious for causing this, so it should be discontinued about 2 weeks prior to getting your test. Other types of conditions like GI, endocrine, cardiac problems, inflammatory disorders, even non-GI cancers can cause elevations in chromogranin A. So if the chromogranin A level is discordant with the imaging, other conditions should be considered or looked for. For 5-HIAA, any tryptophan, serotonin-rich foods can cause high elevations. So foods to avoid maybe 2 days before your test would be these ones listed here, like avocados, bananas. I'm not going to name them all, but they're all listed here. Similarly for PNETs, which actually have a whole bunch of different syndromes depending on the hormone that's secreted, several things can be checked depending on what your symptoms are. But again, NCCN guidelines don't recommend checking if you're asymptomatic. So now moving on briefly to treatment, and I know you're going to get a more thorough talk about systemic therapy later on. So it really is a multidisciplinary approach to treatment, so involving surgery, interventional radiology, and medical oncology. So typically, ideally, you should be seen at a specialized center with experts in all these different areas with an interest in neuroendocrine tumor. So in terms of systemic therapy, one of the goals of systemic therapy is to treat the clinical syndrome. So somatostatin analog is the mainstay of treatment. Octreotide was the first synthetic somatostatin analog that was made in the 1980s. It has the highest affinity for somatostatin receptor 2. There are both short-acting and long-acting formulations. And for somebody with significant symptoms, they should be on a short-acting formulation for 2 to 3 weeks to cover them until the long-acting formulation gets to steady state levels. And then there are 2 other somatostatin analogs that are a bit newer, so lanreotide and pasireotide. Lanreotide has similar binding profile to octreotide. Pasireotide seems to bind a couple of more receptors, but they both have been shown to be equally efficacious as octreotide, not better in terms of controlling carcinoid syndrome. And later on, you will also hear about this new drug, telotrestat, which is an enzyme that blocks serotonin synthesis as a way to treat refractory carcinoid syndrome. So now talking about systemic therapy, that's the other part of systemic therapy, to treat the actual tumor, to control tumor growth. So this is indicated for patients with advanced unresectable GP nets with significant tumor burden. And the selection of therapy really depends on whether you have carcinoid versus PNET because they behave differently, symptoms and the pace of growth. And the choices are somatostatin analog, PRRT, molecular targeted therapy, or chemotherapy. So in addition to controlling symptoms, studies have shown that somatostatin analogs actually have anti-tumor effect. So here's just a figure showing the somatostatin analog binding to the transmembrane receptor and actually inhibiting a whole bunch of pathways downstream, including the mTOR pathway. And the end result is inhibiting cell growth, promoting apoptosis or cell death. In addition, it also has effects on the on other pathways from other growth factors. This is just another diagram summarizing the effects of somatostatin analog. Not only does it affect directly cell signaling inside a cell to prevent it from growing, it also has effects outside the cell in the tumor microenvironment by affecting blood vessel formation in the microenvironment as well as modulating the immune system. So the PROMIT trial was the first trial to show the benefit of octreotide. And in this trial, patients with well-differentiated mid-gut nets who were treatment naive received octreotide versus placebo. And just briefly, it showed a benefit in terms of time to progression. There was no improvement in overall survival. And both functional and non-functional tumors benefited. Lanreotide was the other trial, the clarinet trial, which in this trial, they actually took patients with PNET, mid-gut, hindgut as well, unknown primary, and patients had to have positivity on the Octrea scan to enroll. And again, this showed benefit in terms of progression-free survival, as you can see by these curves. So basically, let me just explain. So the top curve is the experimental arm, patients who received lanreotide, and the bottom curve is the placebo arm. So separation in terms of progression-free survival means there was benefit in the experimental arm. This is just basically illustrating that lanreotide had benefit in all subgroups of patients, regardless of the characteristics of the tumor. So we know that patients with somatostatin receptor expression on the tumor tends to respond better, so it is a predictor for benefit. So typically, that's why you get the imaging. If your imaging is positive, then there's a better chance that you could respond to somatostatin analog. So in terms of side effects of somatostatin analogs, injections, site pain is common, nausea, a lot of GI issues, but they tend to dissipate with time. The more injections you get, hyperglycemia can happen. And one notable thing is biliary changes. Patients can get gallstones, biliary sludge. So sometimes actually prophylactic cholecystectomy is recommended for patients who will be on long-term octreotide. The alternative is basically getting regular abdominal ultrasounds to look at the gallbladder every few months. So PRRT is a new technique, and hopefully it will be approved soon. But basically, it's again just like the radio label tracer that I talked about for the dotatate scan. This is taking basically the same thing, a radionuclide with a chelator linked to the octreotide or somatostatin analog. This allows direct delivery of the radioisotope on the tumor cell. And again, it's been used actually in Europe since 1990s for somatostatin receptor positive, well-differentiated GEP nets. And currently, it's been shown that lutetium-177 is the optimal radionuclide used for this application. So this is a key trial that's been recently published in New England Journal of Medicine. The NETTER-1 trial testing patients who basically refractory to octreotide, randomizing them to this treatment, PRRT, versus, this like PRRT plus octreotide versus high-dose octreotide, as you can see here. And essentially, the patients receive 4 infusions of PRRT, 8 weeks apart, and then they continue on octreotide afterwards. And because of potential renal toxicity, patients get an amino acid infusion during the infusion of the PRRT. So these are the results of the trial, and as you can see, there was a significant increase in progression-free survival, and also overall survival seems to look promising, even though the data has not matured yet. And this is again showing that PRRT has benefit in all the subgroups of patients, regardless of the grade of the tumor and the tumor characteristics and the age. There was overall an 18% response compared to 3% in the control arm, so quite superior. In terms of toxicities, nausea, vomiting listed here. Actually, the vomiting seems to be related to the actual IV amino acid infusion rather than the actual treatment. And in terms of grade 3 and 4 toxicities, which are more significant, there's a potential risk for dropping the blood counts, and that did not happen in the control group, only in the PRRT group. In this study, they did not find any renal toxicity, and previous studies have shown that this treatment can lead to potential long-term risk of MDS and acute leukemia in 2% of patients. In this trial, 1 patient did develop MDS, or myelodysplastic syndrome, thought to be possibly related to PRRT. How are we doing for time? Okay. So I'm not going to go into detail because I know you're going to get a talk about this later, but essentially in terms of target therapy, there are 2 types right now. We're multi-kinase inhibitors and also inhibitors of the mTOR pathway, which, as I mentioned, is important. So everolimus was tested in RADIANT-2 for patients with all kinds of NETs with carcinoid syndrome. And this actually just missed statistical significance. So then they went on to do 2 further studies with everolimus, one in PNET specifically, and that showed a significant benefit. And this led to the approval of everolimus for PNETs. And this is just showing the response, the percent decrease in target lesion size in the experimental group versus the control group. As you can see, there's a lot more patients who had tumor shrinkage. RADIANT-4 is using everolimus in GI and lung nets, well-differentiated nets. And this showed significant improvement, again, in progression-free survival. More the same. So yeah, and the benefit was seen across subgroups. So this led to the approval of everolimus in GEP nets. In terms of toxicities, most important toxicities are stomatitis, mucositis, diarrhea, fatigue, infections, and rash. And there's a low risk of causing pneumonitis or inflammation of the lungs, as well as hyperglycemia or high blood sugar. Sunitinib is the other target therapy that is available now, and it is a multi-kinase inhibitor that targets several receptors listed here. Okay. So this was studied in PNETs, where patients were randomized to sunitinib versus placebo, And this, as you can tell by the curves, there was a significant improvement in overall survival and progression-free survival. So again, this is a difficult drug to tolerate with a lot of side effects, diarrhea, nausea, fatigue, but also potential for hand-foot reaction and neutropenia. So there are ongoing studies for target therapy in carcinoids. Some of the ongoing studies include some of these drugs listed here. They're mostly multi-kinase inhibitors. There are some phase 2 trials showing benefit, but of course we will need to wait for the randomized phase 3 trials. Chemotherapy in general, we don't think that carcinoids respond that well to chemotherapy, but when there are no more treatment options, it can be considered. On the other hand, there's been more data for benefit of chemotherapy in peanuts. And in fact, it can even be considered early on if patients have a lot of symptoms, have bulky disease, because we believe that chemotherapy likely works faster than somatostatin analog therapy, or target therapy for that matter. So just want to point out the combination of temozolomide and capecitabine, which has shown promising results recently. And this was a phase 2 trial that is still ongoing, but the interim analysis was presented in 2014 at ASCO. And you can see that 28 patients were enrolled and they received Xeloda and temozolomide with an objective response rate of 43%. And 41% in carcinoids, with a complete response of 11%. Also, the median progression-free survival was over 20 months, which is quite significant. So these are the treatment options, just summary, for carcinoids and PNETs. Typically, we start with the somatostatin analogs, and if patients progress for carcinoids, everolimus can be considered PRT when it becomes available, of course. And last resort would be cytotoxic chemotherapy. For PNETs, there are a little bit more options. So we would start with somatostatin analog, and after that, if there's progression, then you can consider any of these and cytotoxic chemotherapy. And there's no data to support any particular sequence. And of course, clinical trials are always encouraged. And that's all. Thank you for attention.